Good morning. Sorry for running a little late here. My name is Florian Eichler, and this is the session on advancements in gene therapy for just so everyone finds themselves in the right session. I'm actually going to do this together with Dr. Yeda Lee, who is also at Massachusetts General Hospital. I thought it would be more interesting to make this a little conversational, and I'm used to from in the past giving talks with Eileen Sawyer, so I was looking for someone to do this with. And this might also help break the ice a little bit. If there are questions or you want to join the conversation, feel free to do that. Brief background, I'm a neurologist who came into gene therapy because I wanted to help my patients with these devastating disorders and single gene diseases, and learned a lot about gene therapy along the way. I do not have a PhD, as opposed to Dr. Lee, who does. So she's the one who's actually thinking through mechanisms a lot more, and we're going to try together to convey some of the concepts, and particularly as we think about some of the science, find the right terminology, find the right language. But there are no wrong questions, so chime in at any point and ask, and I love to be interrupted, so don't be shy. Briefly, our disclosures. So we're going to kick off by just speaking to this world of gene therapy, requiring an understanding of some of the terms that we're going to be using, everything from healthy genes to mutant genes, disease genes, the use of viral vectors, why are they needed, what do they do, and how we use these viral vectors to transport corrected genes into cells to deliver healthy copy of genes. And so the place to start is really to explain briefly what disease-causing genes do and where they first cause trouble, which is within the cell, and how we very much depend on targeting cell types in order to deliver corrected genes back and help alleviate the diseases. So I thought maybe I can ask Yeda to just talk through what the role is of genes and DNA.
Yeah, sure. Thanks, Dr. Eichler. So DNA is the code that encodes every single protein in your body. And by protein, I mean these little structures that make up everything in your body. So DNA gives you the code, and in the cell, DNA is something that is meant to be long-lasting, that should be there for your entire life and needs to encode things your entire life, so it needs to be very stable. And in the cell, when your cell is ready to produce protein, the DNA gets converted into RNA, which is a structure that's less stable than DNA, but more versatile than DNA, and can produce many different proteins based on one single bit of DNA. And finally, that RNA, after it gets produced, then gets read by your cell and turns into the actual protein that your cell needs to function. So this is the backbone of the technique and the theory what we use to design gene therapies.
Great. And maybe, Yeda, you can next explain to us what kind of delivery system we use to deliver corrected genes.
Sure.
So here you see, this is an AAV capsid. AAV stands for adeno-associated virus right here. This is the virus capsid, which is the outer shell of the virus that protects the DNA that is inside the virus. And what's most important about this shell is that it also tells you what type of cell in patients this virus can go into. The DNA in here is not virus DNA, so it doesn't hurt us, but we're basically hijacking the virus system to convince the virus to express the gene and make the protein that a patient needs in order for the cell to function properly. And here you can see that this is the construct, so the actual DNA that goes into the virus. There's two important components. This is the actual gene, which we call transgene, because it's an artificial gene that we put in to the cells. And this is the promoter, which is actually what controls the transcription of this DNA into RNA. And this promoter is very important because it controls how much gene is expressed, and it can also control which cell type the gene is expressed in and what time the gene is expressed.
Great. You want to do the next one?
There we go. Okay. So here you have, again, the virus, and this is an empty capsid, but it has a lot of spikes, which tells it which human cell it can go into. And then here you have the usual DNA virus, and finally you put in, this is what we end up putting into the virus, this is the transgene, and it'll go into the human cells.
Good. And now we're going to pick up the pace a little bit to now give you examples of how we apply some of this gene therapy in different forms to 3 disorders. We're going to talk about X-linked adrenoleukodystrophy, and we're going to talk about Canavan disease, and we're going to close with some work on Alexander's disease. But just to point out some of the common themes here, these are all single gene disorders. So here, the example of X-linked adrenoleukodystrophy caused by a single gene called ABCD1 that encodes a protein called ALDP. And the important thing to know about this disorder is that it causes 2 main neurologic phenotypes. 2 ways this can manifest. One more prominent in childhood, known as childhood cerebral ALD. This is acute brain inflammatory demyelination, which, for those of you familiar with this disease, causes lesions and lesion burden on MRI with contrast enhancement, but very different, the adult form, which is adrenomyeloneuropathy, where the brain MRI is usually normal, but you see a degeneration of the spinal cord occurring, causing gait difficulties, balance difficulties. And we're going to argue that you need for each one of these a different gene therapy approach, and hopefully I can explain that. So just briefly, 2 different gene therapy approaches that we will be touching upon is, on the one hand, AAV-based gene therapy, which is a direct delivery into a target organ. This direct delivery can either be into the spinal fluid or into the brain or into the bloodstream. And on the other hand, an ex vivo lentiviral-based gene therapy, where you usually have to harvest cells from the boys themselves and then transfect them, deliver a healthy copy of the gene, similar to a construct that you just heard from Dr. Lee, and then you give the cells back. And so important to keep in mind these 2 different terms, in vivo and ex vivo gene therapy. And we know that all of these terms can be confusing, but I think it's very important to distinguish them. And to give you a little orientation, we have an in vivo AAV gene therapy trial underway for for AMN, and an ex vivo gene therapy trial that was completed for childhood cerebral ALD. These target different cell types, and we also thought it'd be important that we got some feedback yesterday that patients and families say, we don't understand why there are all these different terms used, so we listed some of them here. So for this ex vivo lentiviral gene therapy approach in cerebral ALD, this is also known as hematopoietic stem cell gene therapy, also known as autologous transplant, also known as ELICell, or now in the commercial space, Skysona. So just that you're aware that these are all the same, denoting the same thing. So what's the rationale for ex vivo gene therapy? It's really based on many decades of experience with bone marrow transplantation. We know that bone marrow transplantation, if performed in the early stages of disease in a patient who has a well-matched donor, preferably a sibling donor, they do very well, and you can dramatically improve survival after BMT. Why does this work? We think this works because there's a zone of microglial cell death right around this, this lesion. What are microglia? Microglia are a curious cell type that I always call the traffic cops of the brain. The traffic cops of the brain are the first responders. They are the ones that are vigilantly monitoring what's happening at every street corner in the brain, and then they rush to any site of injury or site of any accident that might be occurring, and they try to clean up. Now, another interesting feature about this cell type is that if it's injured, it has the potential to recover from the bone marrow. And we think that is exactly what happens with bone marrow transplantation, that bone marrow-derived monocytes after transplant enter the CNS and differentiate into microglia-like cells expressing now normal protein. Now, that would be all well and fine. The problem is with bone marrow transplantations from an unrelated donor, you get engraftment problems, you get graft versus host disease. So a few decades ago, there was a very innovative approach. Before I get to that, just to highlight that same principle for targeting microglia is also relevant to metachromatic leukodystrophy, and I want to highlight that that both of these diseases have seen incredible advances in gene therapy, and you can see that here with a conventional transplant, the lesion that usually you see spreading in the white matter is dramatically improved after a successful transplant. This is a beautiful paper by Nicole Wolf in Amsterdam, and she showed also an autopsy of patients who had gone through transplant that you could see donor cells, in this case, donor cells from of the Y chromosome, so from a boy who, in a transplanted girl, proving that really the cells were coming from the bone marrow lineage and going into the brain. So this was really nice proof of concept that microglia are really important for rescuing disease progression. So now I come back to why do we need better approaches? Because we do suffer engraftment problems, graft versus host disease, reactions to a foreign donor having been administered to the patient. And we use now the bone marrow cells from the boys themselves in ALD to transfect them with a lentiviral vector, delivering a healthy copy of the gene, give this, these cells back to the boys after a brief amount of busulfan and cyclophosphamide, and then watch them for a 2-year period. This is identical to a conventional bone marrow transplantation, with the only difference that these are now cells from the boys themselves. And we'll just highlight that this led to gene therapy approval for childhood cerebral ALD, but Libmeldi for metachromatic leukodystrophy takes a very similar approach. And so we've seen actually the first 2 approvals for gene therapy in the space of leukodystrophies, both building on that same principle of bone marrow transplanted cells that are able to deliver and correct mutant cells in the brain. So just to highlight, in childhood cerebral ALD, there were 2 trials that were performed. Each trial used a little bit of a different conditioning regimen. This is the kind of chemotherapy that we use in order to wipe out the bone marrow and make room for new cells to arrive. And we have fancy names for these chemotherapies. In the first trial, we used cyclophosphamide, and in the second trial, we used fludarabine. And we had about equal numbers of patients who were using one versus the other conditioning regimen. Just to highlight that in the 67 patients in these 2 trials, the MRI lesion change is stabilized, and we saw that most of these patients either stabilized immediately. You can see here, this is a score that goes actually from 0 to 34, and the lesions here stabilize either in the first year or after in month 12 to 24. Same is true also for neurologic function. We use something called the neurologic function score, and we can see that most of these patients stabilize, and 94% achieve stable neurologic function without major functional disabilities. Some of the patients who we treat too late or who are progressing too quickly at the time of treatment, they unfortunately do worse, and we had one patient who succumbed to disease progression because we got to them too late. So, so far so good. So we know the treatment works, but unfortunately there are side effects and adverse events, and I'll have Dr. Lee talk through the mechanism here.
Sure. So this is something that's very important whenever we design new therapies and initially start to give these new therapies to patients. So here we've basically found that this lentivirus, this viral delivery, increases the risk of cancer. And so, where's the pointer? There we go. So here you see that this is the virus that attaches to the cell, and here I'm showing you the life cycle of the virus so that we can understand why this viral delivery is associated with cancer. So here, this is the virus. It attaches to the cell and it deposits the DNA into the cell. And this is the DNA that encodes the transgene, so the normal healthy gene that is going to be used to correct the abnormality in the cell from the genetic mutation. This is the inside of the cell, and this is the nucleus of the cell where the native DNA resides. And basically the DNA from the lentivirus enters the nucleus, and here it actually integrates into the native DNA. So there are some advantages of integrating into the native DNA. Not every virus does this, but there are key advantages here in that, one, because it's now part of the native DNA, it does promote long-term expression, so the cell continues to be corrected. One, and two, the expression is very stable because DNA is pretty stable. And also, if this cell happens to divide and create a new cell or 2 new cells, both of those new cells would continue to express the normal healthy gene that the virus delivers. Now, having this integration also has its risks, and the risk is due to the fact that we don't know how to control where the virus integrates into the DNA. We know that most of the DNA is kind of a black box, and we're not really sure what the function of that DNA is in every cell. But there are key parts of the DNA that's very important, including the DNA that encodes genes related to cancers. And if the virus integrates into a gene that causes cancer or is related to cancer or regulates how the cell divides, then that does increase the risk for cancer. And so that's why we can have a problem here. So unfortunately, with some of these boys, I think 7 now, we have seen myelodysplastic syndrome, which is a precancerous state, and it's technically considered a malignancy or a precancer. And this is a syndrome that impairs blood cell development in the bone marrow. So the bone marrow is responsible for producing red blood cells, white blood cells, and platelets. And when there's impairment in this, you can get the symptoms listed associated with red blood cells, white blood cells, and platelets. And these are some of the symptoms that we look for when we monitor the boys who've received this gene therapy closely. So I do want to point out that even though the gene therapy for MLD does use the same type of therapy modality, we have not seen MDS for Lameldi, for the gene therapy for MLD. So to briefly look at these are 5 patients who have gotten MDS. And I just want to bring your attention to the fact that 4 of these patients received fludarabine, and this patient received cyclophosphamide. Again, these are the chemotherapies that condition the bone marrow and open up the bone marrow niche so that the transplant can work. We know that fludarabine does not cause MDS in patients who get allogeneic bone marrow transplants or transplants from other people. However, this is something that we really don't understand, whether there's some interaction between fludarabine and the gene therapy we're giving patients and how this really works. So there's a lot of work going on right now trying to better understand this and to figure out how we can prevent this from happening.
So just to summarize here briefly, we've now had more than 70 patients with childhood cerebral ALD treated with ex vivo lentiviral gene therapy to date. Most patients, 94%, achieve stable neurologic function without major functional disabilities. As mentioned before, the myelodysplastic syndrome does continue to be of concern. We now, in the commercial space, are using cyclophosphamide only, and we're hoping that that will, as previously seen, be much safer than the conditioning regimen with fludarabine, but there are many things we do not understand. So now just turning from ex vivo lentiviral gene therapy to in vivo AAV gene therapy, as we outlined before. So why would we use in vivo AAV gene therapy? And I'll have Yeda again briefly give some background.
Okay, thank you. So this is an AAV a viral vector, which is different from the lentivirus vector that we discussed previously. So the AAV, like the lentivirus, also enters the cell through the capsid. There are certain receptors on the capsid, proteins on the capsid that bind to cell receptors, and then the cell will take the virus in. And again, the AAV will then deliver the gene, the healthy gene, into the nucleus where it can be expressed. But the biggest difference between AAV and lentivirus is that this gene classically does not get integrated into the genome. Instead, it stays independent. Most of it stays independent as an episome in the nucleus, which means it replicates independently from the rest of your native DNA. It is not actually attached to the native DNA.
First time we're trying this together, so bear with us. So it's a bit of a dance. So why would we use a different approach for the spinal cord disease? And this just shows you a little overview of the anatomy. This is the back, the spine, and the spinal cord. And we were very much inspired about 15 years ago by work ongoing by Brian Casper who brought about gene therapy for SMA through delivery of AAV9-mediated gene therapy to these children who are affected in a certain motor neuron in the spinal cord, the lower motor neuron, and this is immediately adjacent to the structures that are important to adrenomyeloneuropathy, namely the corticospinal tract and the dorsal column. So everything that controls your motor performance, the spasticity and the weakness that patients experience, as well as the balance problems that are mediated through the sensory tracts. So the fact that this cell type for SMA was so closely adjacent to these structures made us wonder whether the same approach could work for AMN. So what did we do? We took an AAV vector, similar to what Dr. Lee described in the beginning of the talk, and we packaged ABCD1, a healthy copy of the gene, into it to target AMN, and delivered this into cells in culture as well as AMN mice. And we showed that we could get into the right cell types, and we could also lower very long chain fatty acids, really becoming a first proof of concept that this might work. And so just to highlight some of the work that went into further proving that this in a mouse model of the disease was also effective, we used an intrathecal pump to deliver into the spinal fluid space. We were able to lower very long chain fatty acids, and curiously enough, these AMN mice also develop spasticity and hind limb clasping, similar to what you can see in the disease, and we saw that that also improved not only after early administration, but also after late administration around a year of age. So this is right now an ongoing gene therapy trial for AMN, conducted both at UMass Worcester as well as in Amsterdam. So are there other diseases that can be targeted by AAV gene therapy? Are there other delivery routes that we could also use? And I just want to highlight here the example of Canavan disease. This is another devastating disorder due to mutations in a gene that encodes spartoacylase. It's an enzyme that usually breaks down a certain chemical in the body we call N-acetyl aspartate, and we can measure that enzyme in urine as well as directly in brain. And these children really never learn to sit up on their own, never sit up independently, have seizures, and families are in dire need for better treatments here. So the rationale for our gene therapy for Canavan disease came from Guangping Gao and Dominic Gessler at UMass Worcester. They, over a decade or more, optimized gene therapy, very similar to how you would start improving upon a certain model of a car that you have, reworking the engine and all its parts, and they showed that they could deliver this into mouse models of Canavan disease. And the important part I want to highlight here is that when they delivered this into the bloodstream of the mice using a driver, or we call it promoter, that directed it all to liver, not even to brain. And even with that driver directed to liver, they saw an improvement in survival of these mice. So this convinced us that we could do this with an intravenous approach, with an IV approach, so we didn't have to deliver here into brain or into the spinal fluid. And you can see here some of the first children that are getting intravenous delivery of gene therapy. However, there are difficulties with immune responses, and maybe Yetta, you want to take a chance to speak briefly to how you think about immune responses.
Sure. when we think about immune responses, we are thinking about them here in the context of gene therapy and the immune response against AAV, the virus, as well as potentially the transgene or the gene that the AAV holds, because the patient's body and immune system have not seen the transgene or the virus before and can, at least in theory, develop immune reactions against those. So here, on the left there are the two different types of immune responses. So the innate immune response is the one that happens very quickly, happens almost immediately after the body sees something foreign, and the adaptive immune system is the part of the immune system that activates, takes about 1.5 weeks to 2 weeks to actually fully activate to fight off this foreign invader, so to speak. So what we've seen with AAV gene therapy is something called TMA, or thrombotic microangiopathy. And we don't fully understand how AAV causes TMA, but there's been some studies that have come out that show that it involves both the innate immune system and the adaptive immune system, and it involves the liver, and it causes a lot of liver inflammation. So something that we do for kids that receive AAV gene therapy is that, one, we give them steroids to treat the inflammation and to prevent the inflammation from getting out of control. And two, we really monitor their liver function very closely to make sure that we catch any inflammation before it gets out of control here.
Great. So despite the immune responses that required steroid administration and adjustments, we have in all patients been able to get past these immune responses. And to our delight, we have seen that the N-acetyl aspartate, remember this is the bad chemical that is so sky high in these children, drops very dramatically here within urine from the classic disease state into lower levels that are usually associated with very mild disease. That happens not only in urine, but it also happens in spinal fluid. And you can see here the drop in NAA in CSF, in spinal fluid, as well as on MR spectroscopy. This is a certain sequence that we perform when we do MRIs. So not only does the NAA drop, but we also see improvements in myelination that are here shown in the first 4 patients that we treated, myelination before and after gene therapy, and you can see each image here is before and after gene therapy. And keep in mind, and it's probably a little hard to see here with the lights on, but what's very dark here and black here is healthy myelin. And usually we don't get myelination in the brainstem or the earliest parts of the nervous system developing. But after gene therapy, these structures are starting to myelinate. So something we never see in the untreated condition. So extremely exciting. And most importantly, we have also seen improvements in function in these children here. Keep in mind that the classic Canavan children, they can never sit independently. And here, these children, here's a child who's showing that she's already bringing her hand to mouth, sitting independently, and here taking first steps. And now she's attending kindergarten and identifying body parts. So very exciting to see this level of improvement in a child with Canavan disease. So just to summarize, we have 10 children with Canavan disease treated so far, either at low dose or high dose. We see decreases in this bad chemical called NAA that shows us that the gene is working. We see first improvements in myelination. We still need more time to fully evaluate that, but we are seeing improvements in head control, sitting ability, voluntary grasp. So we think this IV delivery of gene therapy can work for a disease where there is brain swelling and likely an open blood-brain barrier. But keep in mind that we need to manage immune responses with steroids and learn more. So our last example is that of Alexander's disease. This is another large head disorder where the children often present with seizures, with developmental delay. There are also juvenile forms of this disease where onset is after 2 years, and these children often have onset of headaches and vomiting. This is due to mutations in a gene called GFAP that leads to a toxic protein. And this raises the question, is there a way to reduce protein expression? Because we know this toxic protein can lead to scar formation within the brain. And if we could prevent that scar formation, that might be a real benefit to these children. So I'll let Yetta give a little outline of the different gene therapy approach, which is that of antisense oligonucleotides.
Okay, thank you. So antisense oligonucleotides. This is quite different from the lentivirus gene therapy and the AAV gene therapies that we've talked about. The biggest difference is that ASOs are used to lower the expression of the gene, of the mutated gene, whereas AAV and lentivirus, the ones we talked about before, are used to increase expression of the mutated gene. Here we use ASOs, and ASOs target the RNA. So remember, the RNA is the more transient form of nucleic acid that gets produced from the DNA. And the way antisense oligonucleotide works is that this is actually a small piece of RNA that can then bind to the actual RNA in the cell that's produced from the mutated gene, and by binding to it, it actually gives the cell a signal to destroy this RNA, and as a result, the protein never gets made. So this is a mechanism that we use to decrease the expression of the protein, of the mutated protein that's associated with, for example, Alexander disease.
So how do we apply this, and how do we think about therapy becoming possible? And here, just to point to Albie Messing's seminal work in applying antisense oligonucleotides into animal models that he had studied for many years, and showing that in both mice and rats, he could target this protein GFAP and lower the levels of GFAP in both mice and rats. And most importantly, he was able to prevent this scar formation from occurring, as you see down here. So this has led to a first trial using antisense oligonucleotides that we administer into the intrathecal space. So this is similar to when you get an epidural, you're delivering into this spinal fluid space, and we're part of a multi-center, double-blind, placebo-controlled trial that is enrolling worldwide. And you can see here some of the first children we treated in our research unit who have gone on to tolerate this treatment quite well. We are still blinded to outcome, so we do not know once the study will be unblinded whether the treatment is better than the placebo, but it is safe to say that we've been able to institute this type of procedure and that patients are tolerating it well. So just to summarize, in animal models, scar formation caused by mutant GFAP can improve after antisense oligonucleotides, and we are delighted to be part of a worldwide study looking to improve gross motor function in patients with Alexander's disease. So I just want to briefly highlight that this is also becoming a more widely used approach, not only in spinal muscular atrophy, also in seizure disorders like Dravet syndrome. And there are now efforts to do this even for ultra-rare diseases where we might not have enough patients for trials. And the NLORM Foundation has been engaging with many different experts and sites in order to see whether we can even bring N of 1 treatments to the clinic. One of the things we struggle with as investigators and as experts is, while we want to increase access to some of these new approaches, we also want to provide evidence that it's working. And that is much harder to do if you only have one patient you're treating. So it's a constant dilemma and question that we face, and how to move forward and also counsel and guide families appropriately. So I will summarize here and leave some time for questions. We've outlined that there are AAV-based approaches that allow for direct in vivo gene therapy. This is different from the ex vivo lentiviral gene delivery, which requires cells to be harvested from the patients and then outside of the body transfected with a lentiviral vector delivering a healthy copy of the gene and deliver them back. And lastly, we showed an example of antisense oligonucleotides as it's being used now in Alexander's disease, just to highlight again that for the ex vivo lentiviral approach, we now have approved therapies for childhood cerebral adrenoleukodystrophy and metachromatic leukodystrophy, and we have ongoing trials for the AAV-based approaches as well as for the antisense oligonucleotides. So things are changing and moving in the field of leukodystrophies, and I think there's good reason to be hopeful. But at the same time, we want to be careful that there are safety aspects, and we need to manage treatment complications. You heard about myelodysplastic syndrome. You heard about the risks of inflammation and immune responses that can occur with AAV gene therapy. And even with intrathecal ASOs, although generally well tolerated, there are side effects of increased intracranial pressure, of headaches occurring. And we have now got a fellowship at Mass General for neurogenetics and gene therapy. So if you know of any fellows who are interested, please pass on the word. We think this is really important in order to train the next generation of physicians and physician scientists so that they can help spread this knowledge and make these types of transformative treatments safer. So just to conclude, new genetic medicines allow precise targeting of genes. Clinical trials are needed to assess safety and efficacy. I often get questions from patients and families, why does everything take so long? Why can't we move faster? And the reason is that from every patient we learn something, and we need to have data review after every patient, particularly in the early stages of trials, and delays are expected with those reviews. I want to highlight the fact that even the same single gene disorder can require different approaches for different phenotypes, so childhood cerebral ALD versus AMN. And while each class of gene therapy has unique side effects, the individual diseases also play a role. And I think we often forget that. We think every class of therapy brings known side effects, and that over time is true, and we're learning more and more, but what happens in every disease also is a little different, and we need to pay attention to that. And ultimately, we need to weigh the risk-benefit for every patient and understand that not one size fits all. So are there boundaries for performing gene therapy? And I just want to highlight how we generally think of this. I want people to realize that gene therapy is not for everyone. We have to do this for those disorders where we know there is the mutations have high penetrance. That means that they really cause disease, they correlate with disease manifestations, that these lead to extraordinary suffering, so that it's justified to do something experimental that might also be potentially dangerous. So we need to really manage and weigh the risk-benefit carefully, and give patients and families freedom of choice, and guide them as to what we know at every step of the way. So I hope that was a helpful overview, and just a big shout out to all the brave families and patients who've participated in the trials over the years. Without them, this could not have been possible. So big credit to all of you who spread the word and support this. Thank you.
I have a question from online. It was early on, and it says, "Hi, I'm Carter Canning's mom, Katie Canning. We are a duo family with the UBTF ultra-rare variant. We have yet to meet you in person due to financial means, unfortunately. I hope this is an okay question. You are working on gene therapy, I believe, but we would like to ask, what are your plans, and where are you at in the research and a cure for medicine for the UBTF? Also, are the funds in the foundation to benefit all of UBTF variants, or just the E210K variant for gene therapy?"
Yeah, so this is a detailed question. I will give a little bit of a high-level overview, but thanks so much. And I know that there's so much unmet need in the field of UBTF. This is another single gene disorder causing developmental delay, balance problems, ataxia. And I think we are in a fortunate situation that there are approaches using antisense oligonucleotides that could be helpful for this disorder, and we're working on this actively. But not to go into too much detail, but you have to here really target one allele only, and we always have two copies of a gene, and if you really have to be able to be so selective to target only one, it can get tricky. We think we've been able to do this for one patient, but we still have to take that antisense oligonucleotide and bring it forward to clinic. So I know this is a long-winded answer to the question, but I think in principle there is hope that we can target UBTF, but at this point we don't know whether the treatments we're thinking of will be able to be scaled up to all.
Okay, and there are a couple little personal follow-ups. If you want to check with me afterward, you can respond here.
Okay. Other questions in the audience here? Sure.
In one of the last Alexander slides, you commented that some of the scars actually were healing in the brain. Did I get that? Is that correct?
So just to be clear, this is work that was still done in animal models, and that provided the proof of concept for us to move forward. That would be the aspiration in humans. Yes, we are hoping for that, but we don't know that yet.
And there were some areas that were labeled V. Were those like vacuoles? Were those vacant spaces in the brain?
Is this on the pathology part? Yeah. So what happens is in Alexander's disease, when you have this mutant protein, it causes something we call Rosenthal fibers, and I simplified that a little bit by referring to this as scarring, but essentially it's a lot of scar tissue forming, and it seems that after you administer the ASO in mice and rats, that does not occur. So I don't recall in detail what that picture was referring to otherwise. But.
Hello. My question is, you've been talking about single gene therapy. How far do you figure for multiple gene therapy? As our daughter has MLC, and there's multiple defects to the gene code. So just curious to see how far along that could be for multiple gene therapy.
So I'm maybe I might just clarify a little bit. I think what you're saying is that there are different genes that can cause MLC. Okay, that doesn't mean that any individual patient is affected by multiple genes. It just means that there are different genes that can cause the same disorder. Okay, and so in MLC, in megalencephalic leukoencephalopathy with subcortical cysts, mouthful. Okay, so you can have different genes causing a similar phenotype, but in each case you would only need a single gene correction. Now it's a good question. Is there a way to find a common pathway or common approach so that you could enroll more patients with the same treatment? I know that there's work happening in Spain with Asuncio Bosch doing some very nice work on gene therapy for MLC. So that is looking hopeful in the mice, and I think there's good reason to think that this will be carried forward over time to humans. Yeah. Great. I think we're at time. Is that right? Yeah. So we're available if you have any questions, and yes, please raise awareness around gene therapy, and feel free to come and ask more questions. We might not have all the answers, but I think collectively we're learning more. Thank you.